Hello everyone, Heather Hames speaking to you from the Division of Emergency Medicine Point of Care Ultrasound Program at Western University. Welcome to this installment of our Practical Point of Care Ultrasound series. The goal of this session is to review the scanning technique, image interpretation, and proper archiving for the abdominal component of the FAST exam. A subsequent screencast will provide a review of some of the pearls, pitfalls, and clinical applications of this study. And as always, please visit us at westernsono.ca for all of our updated ultrasound resources. The goal of the FAST exam is to look for free fluid in the peritoneal cavity. In the setting of trauma, this is presumed to be blood or hemoperitoneum. While this is not always the case and false positives are possible, in the trauma setting, assuming the fluid you are seeing is blood and acting accordingly is the safe call. When blood is introduced into the peritoneal cavity, presuming there is no restriction to flow, it will move downhill, so to speak, and accumulate in the three most dependent parts of the abdomen. In the supine patient, we look for blood in any one of these three potential low spots. For blood originating in the lower part of the abdomen, this corresponds to the pelvis. For the upper abdomen, this corresponds to the right upper quadrant and the left upper quadrant. Let's take a closer look. Free fluid in the peritoneal cavity will flow throughout the abdomen, preferentially in the relatively unobstructed right and left paracolic gutters. Of these, the right paracolic gutter is deeper and wider, making fluid more likely to flow here, and therefore making the right upper quadrant the most likely location to accumulate blood in acute hemorrhage. In addition, the phrenicocholic ligament blocks some flow to the left upper quadrant, making the accumulation of fluid there slower. Blood may accumulate in the pelvis, either by a bleed originating in the lower part of the abdomen or by overflow from the upper abdomen as it tracks along the paracolic gutters. Because there are three dependent locations where fluid is most likely to accumulate in the supine patient, the FAST abdominal exam is comprised of three separate views of the peritoneal space: the right upper quadrant or hepatorenal interface, the left upper quadrant or splenorenal interface, and the pelvis, which in males examines the interface between the bladder and rectum, or the rectovesicular space, and in females interrogates the space between the bladder and the uterus, or the uterus and the rectum, also known as the pouch of Douglas. The result of the abdominal FAST exam has three potential interpretations. If free fluid is identified in any one of the three views, then the scan is called positive. If all three views are adequately seen and there is no free fluid identified, then the scan is negative. If one cannot adequately see all of the components of the three views, the scan must be called indeterminate. A later screencast will outline sources of false positive and false negative scans, as well as a suggested algorithm to interpret positive, negative, and indeterminate scans in the setting of trauma. As you will recall, there is a common approach that can be applied to scanning in all of the basic applications of point-of-care ultrasound. The anatomic landmarks are reminders of where to place the probe on the patient's body when beginning a study. The sonographic landmark is an identifiable structure on the screen that tells you that you are in the right location to begin looking for your area of interest. And of course, the area of interest is the target of the study and the area you are looking to evaluate for positive or negative findings. In terms of approach to scanning, let's examine the upper quadrants first, as your approach will be the same. The anatomic landmark is the epigastrum at the mid-axillary line. The sonographic landmark is the double density of the kidney. And the area of interest is the hepatorenal interface or the splenorenal interface. This is the image you hope to obtain when viewing the right upper quadrant. As you do more and more scans, you will begin to immediately recognize the sonographic landmark, the telltale double density of the kidney. Immediately adjacent is the solid organ density of the liver. The bright echogenic line between the two is the area of interest, in this case, the hepatorenal interface. Similarly, here is a view of the left upper quadrant. You can recognize the sonographic landmark of the double density of the kidney. Adjacent is the solid organ, in this case the spleen. The bright echogenic line between them is once again our area of interest, and on the left side is the splenorenal interface. Additionally, in the left upper quadrant, we identify the curved bright white or echogenic line on screen left. This is the diaphragm. This is also a key structure to identify when performing the left upper quadrant scan. As we will see in a minute, the search for free fluid must include a slow sweep through the area of interest, the hepatorenal and splenorenal interfaces respectively. But the left upper quadrant scan is not complete until this part of the diaphragm is seen and swept through. We call this area the 6 to 9, referring to the area on a clock face between 6 and 9 o'clock. Because the spleen is small and mobile, there is a chance free fluid may layer between the spleen and the diaphragm, so we must look and sweep through this area too to ensure we don't miss subtle or early free fluid. Now let's take a look at some pelvic scans. For the pelvic component of the FAST exam, the anatomic landmark is the symphysis pubis. In this case, the sonographic landmark is the large anechoic bladder. The area of interest is the space between the bladder and the rectum in males, and between the bladder and the uterus and the rectum in females. More details relating to the pelvic scan can be found in the OBGYN screencast, as the technique is the same. For now, let's examine some typical images in the male and the female. In the longitudinal female scan, free fluid is seen here between the bladder and the uterus, and here in the pouch of Douglas between the uterus and the rectum. In the male longitudinal scan, there is no uterus, so we look for free fluid behind the bladder in the rectovesicular space. The transverse female scan is shown here. Once again, we look for fluid between the bladder and the uterus, and between the uterus and the rectum. Once again, the male transverse scan is shown below. We look for free fluid here between the bladder and the rectum. Now let's look at some examples of positive images. Free fluid or blood is anechoic and therefore shows up as black on your ultrasound. When sweeping the interface, if you see black where there shouldn't be any, that is a positive scan. Here is an obvious example. This scan shows a more subtle example of free fluid. If you missed that subtle example, let's watch again. Similarly, in the left upper quadrant, we can see free fluid in the splenorenal interface. We just want to stress once more that it is important to visualize the entire interface and sweep it in order to call a negative scan conclusive. On the left upper quadrant scan, this includes the 6 to 9 and the caudal tip of the spleen, and also the caudal tip of the liver in the right upper quadrant. In both these cases, free fluid may have been missed if the entire interface was not visualized. It is often very difficult to see the entire interface in one sweep. You may need to move your probe in order to do so. To ensure no parts are missed, though, there should be at least 50% overlap of the images. So let's talk about image generation technique. As with all of our basic applications, this point of care assessment can be done with either the curvilinear or the phased array probe. Either of these probes can be selected from the Triple Connect system on all of our Sonosite units. As you begin your training, you may find the curvilinear probe easier to use. Many find the nature of this probe easier to grasp probe technique, and a larger footprint may make it easier to locate your radiographic landmarks as you are learning. The smaller phased array probe is equally suitable. Because it has a smaller footprint, it is sometimes easier to navigate between the ribs to avoid the rib shadows, which can often obstruct a full view of the interface. Once the probe is selected, we can set its initial depth to greater than 18 centimeters to be sure we are seeing deep enough into the abdominal cavity. As a reminder, the depth buttons are located here on the keyboard and will be shown here on the screen. Let's have a look at the right upper quadrant scan. Remember, the anatomic landmark is the epigastrum, and the scan is started in the mid-axillary line as shown here. The probe is held in a relaxed manner, supported underneath by your 4 fingers and balanced on top by your thumb. It is easy when first starting to hold the probe very tightly, but this is not necessary. As this scan is done in the longitudinal plane, the probe marker will always be towards the patient's head. Remember to keep your hand balanced and always move in only one plane at a time. To locate the radiographic landmark, the double density of the kidney, move the probe first posteriorly towards the stretcher. Remember, the kidney is a retroperitoneal structure and is most likely more posterior than you think it is. Don't give up until the probe hits the stretcher, or keep going until the probe hits the dirt, as we like to say. If the radiographic landmark is still not identified, then move longitudinally towards the patient's head or feet to try to find the best view of the kidney. Only when the area of interest, the interface, is seen should you adjust your depth so the image is on the center of the screen, then plant the probe, keeping it still on the patient's body, and perform your slow sweep posterior and anterior through the area of interest. This same technique is repeated on the left for the left upper quadrant scan, but because the spleen is smaller, more mobile, and more posterior, it can be a technically more challenging scan. This video shows the proper positioning and sweeping technique for the pelvic portion of the FAST exam. First, we sweep in the longitudinal plane in both directions to ensure there's no free fluid. Then, we switch to the transverse plane, once again sweeping through our area of interest and looking for free fluid. As part of your training and for quality assurance, we require clips to be saved in QuPath. A tutorial reviewing this software can be found on our website. While archiving your studies, be sure your upper quadrant scans include slow sweeps through the interface and tips, as well as the 6 to 9 view of the diaphragm in the left upper quadrant. Please note that this likely will require several overlapping clips on each side. Also be sure to archive a longitudinal and transverse sweep through the pelvis. So this concludes our introduction to point-of-care scanning techniques of the abdominal FAST exam. Be sure to review the next screencast in this series, where we will review the clinical applications, pearls, and pitfalls of this study. You can find all of these resources at westernsono.ca.